Sounds good.
Okay. Go ahead and make you. Give me just 1 second.
Yeah, no worries.
Okay. There we go. Okay, so you should be able to share your screen now.
All right. All right. Everybody got it? This looks good? Or
Yep.
Can you see it? Okay, awesome. All right, so my name is Adam Murray. I'm a state trooper flight medic with the Aviation Command. My role in the Aviation Command is I'm part of our training staff. So my job is to train the other flight paramedics, and then as a bonus to that, I get to kind of travel around the state and fill in just about anywhere. So I think I've done a mission. I think I've done a mission at every base so far. So, but primarily my experience is Trooper 2, Trooper 7 in the Southern Maryland region. But I've done an awful lot of crossing the bay because a lot of times you'll get 2 7, stuff like that. Mostly 1 up on your end, but a lot of times you'll get us crossing over. The objectives of this training, we're going to talk a little bit about the whole blood transfusion program, talked about some of our changing capabilities in terms of flying in bad weather, so in instrument flight conditions, and then talk a little bit about some of our kind of other missions that we do that it would be helpful for you guys to have some familiarity with. And finally, we can't have a talk with ground guys without talking about some landing zone safety and operations, so we're going to try and drill down to that a little bit. So the big headline for this is that whole blood is now on board all aircraft for immediate transfusion. So we started this program back in March. Well, we started trying for this program several years ago, but the blood actually came on the aircraft in March. We started initially with 2 units on Trooper 1 and Trooper 2. And then we kind of expanded as blood supply allows to now where we have at least 1 unit on all 7 bases. Now I say at least 1 unit because typically while we have 2 units, if a crew administers 1 on a call and they can't immediately restock, they'll sometimes only have 1. But usually 1 to 2 units on every aircraft. Our goal is that we can restock anytime we go back to shock trauma or a Baltimore area hospital. So our blood bank that we're using is the University of Maryland's blood bank. So we go there to restock. So as we administer it, sometimes on the second, third flights, that kind of thing, we might have cases where we don't have it on board, but that should be very few and far between. Currently, we've given, as of a couple minutes ago when I checked, we've had 21 transfusions since May 10th. Sorry, not March, May. So since May 10th, when we first put blood on the aircraft, we've had 21 patients to receive blood and then 24 total units. So some of those patients got 2 units. I'll talk about this a little bit when we get into the physiology and talk some about like resuscitation. But one of the things that we've noticed kind of anecdotally with that small sample size is that by starting the transfusion significantly earlier in the pre-hospital arena, we've been able to decrease the amount of overall blood products that the patients get. For the most part, the patients that we're giving blood products to, we give them a unit, and they tend to do well until they arrive at the hospital, where they frequently get subsequent units, but it's enough to kind of keep them from getting into that really, really deep shock. For a lot of the patients where we've given 2 units, some of those have been in traumatic arrest. So we can give blood in trauma arrest. That is one of the reversible causes that we're immediately going to treat. So we'll talk about this a little bit more, but please don't cancel us if we're coming in short. Almost to your scene, your patient goes into trauma arrest. Don't cancel us. Let us come there and help you out. But like I said, as of June, all 7 bases have blood on board, ready to go. So the goal of the program is that we are going to try and replace what patients lose. One of the things that we miss when we give a lot of like crystalloid fluids is crystalloid fluids carry oxygen. So let's just say, you know, if you have a patient that's lost a lot of blood and you replace that blood with crystalloid fluid, you might improve the number of blood pressure, but it doesn't particularly improve their oxygen carrying capacity. So it might not get them out of that hypoxic state that they're in at the cellular level. And in addition to that, it a lot of times will dilute clotting factors. So it can sometimes make their ability to clot significantly impair that ability to clot. So we're going to talk about a patient kind of woven throughout this whole thing. So this is a similar, objectively similar to a patient that I had. But this is a 70-year-old female with a head-on MVC. So on our primary assessment, when we do a rapid trauma, some of the things that we notice is that paraorbital ecchymosis and large hematoma on the left side of the head. You've got bilateral femur fractures, an open fracture on the right with severe external bleeding. The right leg also had a tib-fib fracture, and you had tenderness to palpation of the pelvis. Of all the medical history that was there, the parts that really matter, the really pertinent part, was that they had a history of fib, and in this case, they were taking Eliquis, so apixaban. So right there, you got a couple factors against you, right? So you have a elderly patient, right? We know elderly patients respond to trauma in different ways, right? And then very severe mechanism injury, right? If this was me with this mechanism injury and this set of injuries, I'd be in for a very bad day, even as a not elderly person, right? So the paraorbital ecchymosis and large hematoma in the head, right? That's right. High suspicion of a severe TBI. Bilateral femur fractures, the tenderness to palpation of the pelvis, right? That's sources of severe internal bleeding, and that tib or the femur fracture on the right being open can cause that significant sorry, I have to let this admit, sorry. All right. Can cause some very significant external bleeding as well. So a lot of things going on here. So as this patient is losing bone, I kind of touched on this. As they're losing blood, they're not just losing volume. Oxygen carrying capacity of that blood. In addition, if we have a patient, for example, that gives you that soft blood pressure, so you've called the aircraft, we're on our way in there, and you get a patient with a blood pressure of 94 or 86, right? That's a pretty soft blood pressure. That's not good, particularly if they have an elevated heart rate. One of the things that we don't want to do is dump a lot of crystalloid fluids into them. So, right, if you're sitting there like, oh man, they had a blood pressure of 90, let's give a liter and a half of fluid. Not only does that not provide the oxygen carrying capacity, clotting factor, the things, right, it tends to make the patient a little bit worse. So crystalloid fluids, even ringers, which is supposed to be a little bit better at this than normal saline, but either one of them will cause a little bit of an acidosis as you give a significant amount of it. So that's all going to lead to more towards a negative outcome of the patient. But the other thing to consider is that if you give that patient that huge bolus of fluid, when we arrive, their blood pressure might be better. So if their blood pressure is now not hypotensive, by our protocol, we can't start the blood, which they still need, right? Because they still don't have the oxygen carrying capacity and the clotting factors. So I understand, there's going to be times where that's all you have, and that's just kind of going to have to go back to, kind of permissive hypotension, right? Giving them small aliquots of fluid, so maybe like 250 cc boluses to keep them at that 80 to 90 systolic pressure while we get them to a higher level of care, right? That might be the better strategy as opposed to dumping a whole lot of fluid into them. Now they have normal, nice-looking vital signs that keep us happy, but they ultimately don't have the stuff that they need. So some of the history of blood product administration in general, right? I think it's kind of helpful to know where we came from. So the early 1910s, early 1900, 1904 is where we're starting with whole transfusion. And whole blood transfusion was the thing all the way from World War I. The problem was, in reality, what they were doing was significantly, they're doing warm blood transfusions where they weren't storing blood for an extended period of time. They were taking blood from one person and putting it into another in that sort of transfusion method. So in the 60s, people started kind of coming into that clear fluid, that normal saline and things like that. And a lot of the driver of this is that blood is great. Blood, it's not that blood didn't work. It's just that blood was hard to store. It was hard to manage, and it's a very limited supply. So you can make unlimited crystalloid fluid, and you can store it really easily. So that's kind of what led that shift to crystalloid fluids. Like, well, it may work just as good as blood with better logistics. And it turns out it didn't. And so as we start getting into the 90s, we start getting into component therapy. So the idea is, all right, we take the whole blood and we break it out into the component parts. So you break it down to the platelets, the plasma, the red cells. And there's a couple of advantages of that. Not only does it last longer in its component parts, but you can give a patient exactly what they need. So if you have a patient that needs some platelets, you don't have to give them whole blood. You can give them just the platelet part that they need. But as we get into 2020 and closer towards the modern era, one of the things that we realize is that for patients that are losing whole blood, the best evidence, the best outcome for them is just to give them back what they've lost. So giving them right back whole blood is seeming to be the best way to do it, because it gives them the clotting factors, it gives them the oxygen carrying capacity, all the things that they need when they lose that whole blood. So the idea behind whole blood transfusion is that we're giving that balance to. So when you're in component therapy, you'd want to give 1 to 1 to 1. So one piece of each of those things to get itself. It is a lot easier to administer, right? So as opposed to hanging 3 different things and making sure that I'm storing and able to maintain those 3 different components, now I just have one bag to take care of. So those are the biggest kind of benefits. Now the difficulty is making sure that you are click that one a little too early, but making sure that you are able to store it and able to protect that resource, because it is a very perishable resource. So one of the major things, so there's a big study here about, and this was kind of talking about the time to transfusion for patients that were severely injured in trauma. So for those patients with the time to, right, one of the biggest things out of this is in that proper trial, they pulled out a subset analysis, and they found that out of that subset, every minute of delay between activation of master transfusion protocol and that arrival of the first or administration of that first blood product, regardless each minute. So by bringing this resource.
Hey, Adam, your microphone is
down.
cutting in and out.
Oh, okay. I'm sorry. Let's see if this is any better. Was it doing it before, or is it just doing it now?
Kind of before, but it had just cut out for a couple of seconds there, so I figured I'd let you know.
Okay, sorry about that.
That's all right.
Let me try. All right. Just make sure we didn't miss anything. But basically, the biggest thing out of the study was that every minute of delay of activation caused that significant increase in the odds of mortality. So we're trying to get the transfusion started sooner. Let's talk about some of the things that we need to do for this patient in our scenario. So our priorities. Well, first of all, we need to control external hemorrhage. So doing like transfusing blood, like doing all those things, but good BLS prevents good ALS, right? If we get there and control that external hemorrhage aggressively, so pack wounds, put on pelvic binders, things like that, that is really going to give us the biggest bang for our buck, because we're preventing the patient from losing out all that blood. So tourniquets on the extremities where applicable. Tourniquets are really useful. It's important to not overuse them, but they are very useful. And if you've got an extremity that's massively bleeding, throw that on there, get it going. Wound packing. So if you have a place that you can't tourniquet, so like the shoulder, the buttock, the upper thigh, groin region, right, where you can't get a tourniquet around, make sure you're packing wounds. So get the hemostatic gauze if you've got it. Make sure you're pushing that all the way to the bottom of the wound tract to the source of the biggest bleeding. And you're continuing to pack that wound until it's completely full, and then you put a solid, good pressure dressing over top of it. Pelvic binders. Pelvic binders are a huge, pelvic injuries in general are a huge source of major bleeding in the patients that we see. So if you've got a patient that has that mechanism that you're suspecting the pelvis might be injured, you're really going to want to throw that binder on. Even if the patient like the pelvis feels stable, the patient doesn't particularly like, if it's just based on mechanism, that's fine. You can throw that pelvic binder on, really easy for them to remove it if it's not indicated. But one of the key things in here, in light of the resource that we're now carrying, is that early activation of aviation. So early activation is absolutely critical. The earlier that you can get us en route is the earlier that we'll actually be there. So initial vital signs for the initial vital signs for this case here. So we got a heart rate of 130, BP is 84/40. You see that end tidal is a little bit low as well. Oxygen saturation is a little bit low, and a GCS of 14. So airway is not particularly the issue. We do want to give her a little bit of supplemental oxygen, but remember, she probably does not have that oxygen carrying capacity to move it around. The biggest things that should pop out of you are those first three. So the heart rate higher than the systolic blood pressure. That's a shock index of greater than 1. Anytime you have a heart rate higher than your systolic blood pressure, you need to be starting to be suspicious for shock. It doesn't necessarily mean that there's no reason that is normally occurring that the heart rate couldn't be higher than the systolic blood pressure, but it should at least raise your suspicion. You should start trying to figure out why. That end tidal of 22, right? End tidal is a fun little thing, but if you don't have the oxygen carrying capacity to move oxygen around to the cells and to move carbon dioxide out of the cells, your end tidal is going to be low, right? So a trending, and in particular, a trending end tidal that is decreasing is a very significant thing to watch out for a trauma patient. So let's talk about some of our transfusion triggers and protocol. So first of all, mechanism of injury, right? We are going to be looking at, right, what's going on to the patient? Is this something where they particularly need blood? So the mechanisms we're looking for: gunshot wounds, stabs, amputations, multi-system trauma, things that are going to be a source of major bleeding. And then in the clinical assessment, we need to have altered LFC that's not as a result of head trauma or alcohol. We're looking for things like anxiousness, weak or absent peripheral pulses, decreased blood pressure, so actually like hypotension, or a positive shock index. If you've got ultrasound and you've got a fast exam, that's great. We don't have ultrasound yet because prior to this point, we didn't have a whole lot of a particular reason to carry the ultrasound, right? Any patient that we're taking is pretty much going to go to a trauma center anyways, and we're not going to delay on scene to do the fast exam, and the hospital is going to repeat it anyways. So up until this point, we didn't have a particular driving force to get that ultrasound. But if you've got it, that's great if you can get it done before we get there. The key thing with the ultrasound and with fast is you don't want to delay what they actually need, which is that blood transfusion, that bright light's cold steel, the actual definitive care at the hospital. And we are probably going to try and get ultrasound starting next year, but now that we have blood as a possible. So this is our protocol. So the cool thing about this is that this is also in your protocol book. And so it is very clear and open, and it can be known to all of us. So knowledge weighs nothing, and knowledge doesn't take up any space. And that's one of the cool things about it, right? So you guys have the same access to this and can know when your patient meets this whole blood criteria just as much as we do. So some of the things that are specifically listed out in this protocol. So you got your clinical suspicion based on the mechanism. So penetrating injury, unstable pelvic fracture, massive blunt trauma, observed major blood loss. And then you need that signs of physiologic compromise. So this is really important. We don't want to be giving blood, which is a precious resource and something that isn't without risk. We don't want to be giving it to people unnecessarily. So we want them to be, and this protocol is pretty black and white, that they need to be relatively sick before we can actually start administering blood. So we want age-defined tachycardia. You want an end tidal less than 25, positive fast if example, or if available. That lactate, if you've got a lactometer, we've been looking for one. So if somebody's got one, let me know. But we haven't been able to find one yet that's good for EMS use. But a lactometer would be great. That capillary reperfusion, things like that. And the biggest thing is that age-defined hypotension. So you got to have the age-defined hypotension and tachycardia, and you got to adjust that for your age. We are giving this all the way down to 1 year old on standing order. So any pediatric patient, anything like that, all ages get the same blood that we carry. We can give it to patients that are under 1 year old. We just have to get medical control first as a layer of, yeah, are you sure? Yes, we're sure. Biggest contraindications are the patient, or basically patient wishes based. So if the patient refuses to take blood, or if the patient has some sort of like medical alert tag indicating that they don't want to be receiving blood. So we do have some populations of like special populations like Amish and some other ones that different places in the state that have objections. So if you know those are in your community and the patient's conscious, maybe that's one of those things to discuss with them as we're inbound. Because that can be useful, and you guys might be the only person to talk to them. But the biggest thing is you have the same protocol as us, so you should be able to know when your patient is going to qualify for blood. And if you've got these things, even if it's not 100%, right, even if you just have a significant suspicion, notify that flight crew as we're coming in. I know a lot of times we do that, right? We do that very simple airway and GCS. So airway, GCS, do you need blood, is pretty much the things that we care about on that radio of call coming in, because that lets us set up and prepare for what we're going to do. So make sure you're letting us know, because one of the other major things about this is the blood is carried in a cooler. The supplies to administer it are carried in a separate bag. That's 2 more bags in addition to the monitor and the critical intervention bag that we already bring to the ambulance. So now we're talking about 2 bags per person. Just a whole lot of stuff to kind of bring around. So we're not going to be bringing the blood to every single call. It will be in the aircraft on every single call, but it will not necessarily make its way from the aircraft to the ambulance. So if you know you need it and you need it right now, make sure you let us know on the radio on the way in. That way we can be sure to bring it. Other than that, our plan A is going to be to, rock through our handoff with you guys, go back to the aircraft and do that transfusion en route. So some of the things that we need to set up for transfusion. So we want a large bore IV. Large bore is specific to the type, right, just the amount of fluid that we can get through it. So we want large bore IVs. We don't have a minimum for IV size. So if you can only get really small ones, or if you have like a kid or something like that, we can give blood through a very small IV line. That being said, we'd like the biggest we can get, because if we're giving blood, we want to give a lot of it. We can give blood via the IO. So IO is fine. IO, we prefer humeral over tibial, simply because you'll get a higher flow rate out of a humeral IO. And then if we can get a large bore IV, we do prefer that for blood administration over IO. So IOs are fine, right? I gave a unit of blood through an IO, through a humeral IO last week, the week before. The problem is it just takes a significant amount of time to get through that IO. Particularly if you have one, like we had one that wasn't flowing particularly well. So if in that case, it might take 10 minutes to get through a unit of blood. Whereas if I get a large bore IV, it might only take me 2 or 3. We are also carrying 12 gauge IV catheters on the aircraft as part of this program. So the 12 gauge IV catheter requires a little bit of it requires like a wire guided technique. It's still a external, or still a peripheral IV line. So if you see us do it, we're not doing anything super crazy. It's not a central line. It's not a cut down or anything like that. It's just a peripheral IV through a different technique, just because of the size of it. But the 12 gauge does exist, and it is something that we might do. But ideally, we want to be connecting direct to the catheter. The reason is, if we take this, right, IV blood administration tubing is a larger diameter than standard IV tubing. if we take that blood administration tubing and then hook it to a standard or a narrow diameter extension set, we're going to significantly cap our flow rate, and we want to get that blood into the patient if they need it. So don't be surprised if we're, like holding that manual occlusion, connecting the whole saline lock, and then putting our blood line directly onto the catheter. This is going to be situation dependent. We can obviously not do that if if it's one of those cases where we might lose the line, but it's going to be up to the judgment of the flight crew. Just know that might happen. Second most common question with all this is, what about TXA? TXA, basically any patient that can receive blood would also benefit from TXA. And the only restriction that we have is that you can't give tranexamic acid through the same IV line at the same time. So you can give it before we get there, you can give it at the same time through a different line, or we can give it after we are administering the unit of blood. So any of those things are options. We do like our patients to receive TXA. If you know we're coming in and you know they're going to need the blood, if you can get it on board, get it on board. That'd be great. So specifically what we're carrying, we are carrying low titer O positive whole blood. So this is blood from volunteer donors that has low levels of antibodies. We filter out the white blood cells. So this is technically leuko-reduced blood. And then you have the citrate phosphate dextrose as a preservative. So one of the things you'll kind of hear sometimes, and you'll kind of you'll hear us kicking around, particularly as the years will go on. I think maybe next year you'll start seeing us administering calcium from time to time in association with this. There's some evidence is kind of strengthening that calcium is beneficial for patients that are losing a lot of blood, and in particular that are receiving significant amounts of blood products. So the calcium sometimes can counteract that citrate, which can reduce clotting factors if you're getting a whole lot of blood. If you're getting 1 unit, it's not a big deal. But with some of these patients that we've taken, we give them the 2 units at shock trauma. They're getting additional units. We can get to the point in some of these massive transfusion protocols where we're basically replacing their entire blood volume with donated blood, and in that case, the citrate does become a significant factor. But our blood can be cold stored for 21 days. We have it for the first 7 days. Every 7 days, we're swapping out our blood, and it's going back to shock trauma. Shock trauma is going to use it in the TRU. So we're carrying the exact same stuff and using the exact same administration criteria and protocol as they are. Now, I will say they're a little bit more lenient because they're doctors, and they can be, on when they actually give the blood. So they tend to, there are patients that we fly where we go, they probably need it, but it doesn't quite fit our protocol, and then they get into shock trauma and they get blood. Biggest thing is our protocol is set up and designed for patients that they're very severely injured. So in those cases, what we'll do is we'll be all set up, we'll be ready, we'll spike the lines, we'll set up the warmer, we'll be ready to go, but we won't always hang the blood until the last second just to make sure that they do meet that criteria. So why are we not using O negative blood? The simple thing is supply and demand. So there just is not enough O negative blood to go around. So a lot of your major trauma centers, as a result of this, to include shock trauma, are using O positive, right? The numbers are there on the screen there. So 7% of the population is O negative compared to 37% are O positive. When you're talking about volunteer donors, that's a huge difference. And that is one of those things that really increases the supply. So we just, if we stuck to O negative blood, there'd be no way for us to actually do this program. We would, the only way it works is with O positive. So is it safe to give that Rh positive blood to people who are Rh negative? And the reality is, when somebody is in severe hemorrhagic shock, the likelihood of a transfusion reaction is very low, because your body is doing other things and shutting down because it doesn't have the blood that it needs to move around. This is another reason why we're not necessarily giving blood to people just to see, right? It's not as benign as like giving somebody some ringers. They have to be pretty severely down on that protocol, because that's one of the things that minimizes the risks. So women of childbearing age, that's another thing, right? We are giving O positive blood to women of childbearing age. There is a specified risk that if they have a kid in the future who is that the child could have a reaction in utero to the positive antibodies. The reality is, kind of like I talked before, when somebody is that sick, there's very, very little chance, and the evidence shows that there's very low chance of them actually generating the antibodies. Kind of just means it kind of boils down to the body having other priorities. So they don't typically recognize and create those O positive or those Rh positive antibodies in the moment. The other thing too is that they have to survive the current injury, and so the risk of imminent death of the patient means we have to give them the blood, right? We can't carry, it's not feasible for us to carry O negative and O positive or just O negative. So we're carrying O positive. And if the choice is, they might die right now versus they might potentially have a complication at some point at a later date, the risk versus benefit is significant towards administering the blood. And the lifetime estimate of a possible significant impairments of a fetus in a future pregnancy is 0.04% in the data. So like I've kind of been talking about for the past couple minutes, there is some risk, but there's also significant benefits. So the benefits to whole blood is that we're actually repaying that oxygen debt. We're giving them a substance that can move oxygen around their body to where it needs to go. We're also giving them those clotting factors. So that hemostatic potential, we're giving them back the things that they need to make strong, quick clots. I talked a little bit about the logistics and the speed, right? We can just hang a bag of fluid pretty quickly. So the biggest thing is we're weighing the risks and benefits of this to try and save lives. So the equipment that you'll see us using, the equipment that you'll see us using. So we on the left here in this tan cooler, that is our Credo ProMed cooler. That is the cooler that we're using to actually physically transport the blood. So if that gets left in your ambulance, call it out on the radio immediately because we're going to want that thing. These coolers are, they basically have an insert inside of them that we freeze, and then that will keep the blood between 2 and 10 degrees Celsius. So just above freezing and very cold. It will keep it in that range for up to 48 hours. Now we're changing out the ice in it, the little inserts. We're changing that every 24 hours, and then we also have a continuous Wi-Fi Bluetooth thermometer that's inside of it that gives us in the blood bank the ability to look and see what the temperature of the unit is at any one point in time. Some other options there. So we have a down here in the bottom center, that is our warmer unit. So this little gray box down there. So we are running the blood through a warmer. So the IV fluid is going to run through that, and it's going to sit in this little styrofoam little box. It's going to plug in on top of that, and then it's going to run out the other end. Basically, cold blood is going to come in one side, and body temperature blood is going to come out the other side at whatever flow rate we run through. So it's a really cool device, works very well. We can also use it with crystalloid fluid for patients that are in severe hypothermia. So if they don't necessarily need the blood replacement, before we started carrying blood, we started carrying these, and I used one in the spring for a guy that fell outside and then stayed outside and was not found for a day and a half. And he was severely hypothermic, and we ended up putting him and running warm fluid through that. So that's one of the other options that we have. This little squirt gun looking thing on the right, life flow gun. So that is specific for pediatric administrations. The key thing there is that it gives us a little bit of ability to get some pressure behind it and some good flow rates through very small IVs. But the core reason that we're using this is that it is a measured administration. So every squeeze of that blue handle there gives us 10 cc's. So we're 10 cc's per kilo. So we just look at them and go, okay, however many kilograms they are, you give them that many squeezes. And that's a really easy way for us to dose and be precise about the amount of blood that we're giving. And finally, this little drip chamber here thing, one of the big things to remember is that we are using a separate set of tubing. So you'll see a Y tubing with a small 250 bag of saline on one end and then the blood on the other. The 250 bag of saline is just for flushing the line. That's it. That's all it's for. And flushing the line in between blood units. But it is a different It is a different set of tubing entirely. So when to call? Early activation is absolutely critical. This is one thing that EMS protocol defines when a patient can be put in a helicopter and transported via air. EMS protocol does not define when a helicopter can be requested. So a helicopter can be requested at the judgment of the incident commander or whatever, right? So if you're getting dispatched to a call where, a good example of this is, right, I was working a shift out of Frederick. I heard a call, the first arriving law enforcement officer, before any paramedics, any EMS, anybody like that was there. The first arriving law enforcement officer got there and said, hey, I've got a serious MVC. One guy's trapped. I can't get to him, but he's unconscious. That's enough information without knowing category Alpha Bravo, right? I mean, we all kind of know that is a category Alpha, but without anything else, that's enough for us to go. So if you're getting that information via a 911 call, via a bystander, you can launch us before you actually get to the scene. And in particular, if it's one of those places where you just know that a serious trauma is not going to get to the hospital by ground, you can get us going. We take about 10 minutes to get off the ground. That's the longest portion of the thing. Once we're in the ground and we're up to full speed, we fly at about 170 miles an hour in a straight line. So I'll show you some demonstrations of this in a few slides, but we can really get places fast once we're off the ground. If we're off the ground, we're en route to you, and the patient isn't as bad as forecast, or they seem to be fine, you can always cancel us. It's not a big deal. But it is important to remember that EMS protocol does judge when we can transport a patient by air. So if we're coming in and the patient doesn't look like they're that Alpha or Bravo, they're looking more like a Charlie or Delta, still get that consult, and you can let them know that we're here, right? But the consult, it has to be approved, and the trauma center has to accept that patient, because we don't want to necessarily clog up trauma centers with patients that don't need trauma center level services. If they just need a simple lac repair or a rule out physical exam or something like that, they can go to the local facility to get that. So we only want to tie up our air assets and our trauma centers transporting patients that actually meet the criteria. But the key thing is, when we do a meaningful intervention for a trauma patient, and that meaningful intervention can be stopping external hemorrhage, securing their airway, whatever, we get a chance to kind of pause time in their decompensation. So one of the things to think about that is, by calling us earlier, we are now going to arrive at the scene earlier, and where you might potentially get that blood started earlier, and now we've paused their further decompensation. So I have to apologize. I was telling Lindsay earlier today, I got tied up today assisting with finding an escaped prisoner, or trying to find an escaped prisoner, and I didn't get a chance to change all of these locations to one in around the shore. But I think they'll still be representative. So this intersection is an intersection in Baltimore County. It's about this is what it kind of dispatch says. So dispatch says a heavy rescue is reported to a trapped patient, and the bystander on the 911 call says the patient is unconscious. So right then and there, before any units arrive on scene, you know enough that if it's in your area, you know geographically it makes sense, you can launch an aircraft right then and there. So looking at transport times to the trauma centers from this location, right? So they have this is a case for them where it's really drive versus fly, right? Because you can drive to you can drive from that scene to Sinai Hospital, which is a level 2 trauma center. You can drive that point in about 17 minutes, and you can drive all the way down to shock trauma in about 27. So this is what you're looking at it from there, right? From you guys, you're going to be fighting Bay Bridge traffic. You're going to be going up and around, or going to Christiana or something like that. Like you guys probably not at the drive versus fly decision making point. But one of the things I want to point out is the difference in our flight time. So for this 17-minute transport, our flight time direct, as the crow flies at our speed, is 2.5. So the biggest thing isn't necessarily, right, when we give you those, all right, you'll have Trooper 6 in 15, 20 minutes. The biggest chunk of that time is actually the startup and liftoff. Once we're on scene, right, our transports are pretty quick. And to give you an idea, for most of our aircraft, from the time you call us to the time we are landing at the hospital is about 40 to 45 minutes. Now, I really hammer on the time you call us because the time you call us matters. If you call us 10 minutes after you arrived on scene, now we're not doing that patient as much good. Whereas if you call us early, then we'll be there much significantly faster. But now you're looking at a 5-minute flight for this 27-minute drive. So that's one of the things one of the major things that we bring is speed, right? We are paramedics just like you guys. We have some fancy tools, but for the most part, we do the same things you guys do. We do it at 170 miles an hour without hitting any speed bumps. Some factors to consider. So weather, we'll talk a little bit more about when and how we can accept patients in inclement weather. But all these things are factors that you as the ground medic should consider. It's kind of like the National Registry skill sheets where, they go through and you're like giving you that trauma board scenario. You're like, oh, what's the weather, right? The weather in this case matters for, can you get an aircraft? And I'll talk about this in a little bit when we get on the IFR, but do you have to get an aircraft by driving a patient to a place that has an instrument approach, right? There might be some of those cases where, yes, I'll get an aircraft, but that aircraft is going to be delayed and I have to take the patient somewhere to meet the aircraft. They can't land on scene. The traffic, time of day, accessibility to the patient. We really like to land on scene and be able to help you take care of a patient in a car. If the patient's still trapped and we can start helping you there, we cut down the time for excessive handoffs afterwards, right? If you only have fire department personnel in the car and they're cutting and doing the things, then they have to hand over to the ground medics to get them out of the car. Then the ground medics have to bring them to the LZ and hand to us. If we get there and get in the car helping you guys with that initial patient care, well, now we cut more handoffs. So that saves us time, saves the patient time. But the biggest determining factor is, what does the patient actually need? You got to figure out, how severely injured they are and whether or not they actually need the blood that we carry, speed that we offer, or whether or not they need to be observed and ruled out. So let's talk about some timelines. The biggest thing here that I kind of am trying to is the old dispatch, is that initial unit, and the 0 after the 911 call, and you go at point, you go, oh man, right after your primary survey, now we're 20 minutes behind. So now 35 minutes into this incident, we have the potential to start that, and we're arriving at 50. On the flip side, if you request us early, so you are requesting us prior to your arrival, you're going, hey, this sounds bad, it's got a lot of things, we're going to go ahead and request aviation. For every minute earlier that you request aviation, you move that blood transfusion, if they need it, potentially up another minute. So now you're looking at, by early activating, you've cut 7 minutes, or 8 minutes off of that time. 7 minutes. Let me do math here. You're cutting 7 minutes off of that time, which for our patients can significantly, it can make a significant difference. So early activation is going to be the absolute key with a lot of these things. And you guys have an advantage in that you are at an area in a G grade that doesn't typically require, or doesn't typically have the option to just drive it to shock trauma themselves. So you don't have to worry as much about that particular decision-making tree. The biggest thing is, if you call us earlier, we can help your patient more when we're there. So this is kind of the bottom line of the whole thing. So the blood is a significant thing that our patients can need and can be benefit from. It's a meaningful intervention, far more than giving any sort of ringers or anything like that. And the earlier you activate us, the earlier we can bring that to the patient side. So biggest thing that you can do to help is donate blood. I get emails and calls from the Red Cross all the time. They're a little bit annoying in that they call me all the time, even the day that I donate blood. They're calling me asking me to donate blood, but the need is great. One of our biggest issues in terms of being able to have 1 or 2 units on the aircraft is the demand. We had cases where over the weekend we donated 3 units of blood on different flights. So we donated 3 units of blood, and at one point the blood bank didn't have a unit to give us back. So that aircraft was down to 1 unit for a while until we were able to get another one. So this is one of those things, if we can help the supply, this is one of the ways that you can help, your society as a whole, your county, your area, and all those things that doesn't involve actually running a call. Right? If you can go and donate blood, that is absolutely crucial for any number of patients. So let's talk a little bit about landing zone safety and setup. So generally, for landing zones, you're going to need we're going to make the decision on where to land. So you guys can set up a landing zone. We'll take a look at it. If it is not something that we like, we'll move around. Not a big deal. We can also pick our own landing zone. Right? If we're coming in hot and you guys aren't there yet, we can land in our own spot. I did a call in northern Baltimore County a couple months ago where the medic unit got on scene and found somebody with a serious degloving injury that was kind of not reported through the 911 system. The way that it was, it was significantly different than the dispatch information. So the medics on scene by themselves, they request an aircraft for a Category Bravo trauma patient for a degloved extremity. And we were actually up for a training flight. So instead of a 20-minute ETA, they got a 3-minute ETA. So the medic is trying to tell us like where to land, what to do. And we're like, hey guys, we can take it. We can figure out where to land. So even with the medic unit in the driveway, we just went around and landed in this person's backyard on our own. It is something that we can do. We like to have our fire department personnel there to secure and do things. That does provide us with a margin of safety. But we also have 4 crew members on board. We can look under, we can open the doors, we can look under and around the aircraft. And we have a very professional aviation program. We can land this thing wherever it goes. So that's one of the things that we can kind of take away from you in terms of workload. Biggest thing is it's helpful to be on the same radio channel. If you see something that we don't, if you see a wire, if you see an obstacle, if something's blowing, if a car is going to drive into the landing zone or something like that, if that happens, anybody can key up on the radio and say go around. So go around is our thing. So if you say go around, we're gonna lift up out of the landing zone, go fly around, and figure out what happened. So that's an easy way to get us out of the way. We look for 150 by 150. So 150 by 150 gives us a little bit of a safety margin. To give you an idea, we're about 50 by 50 for the actual footprint of the helicopter-ish. So 150 by 150 gives us a little wiggle room. We can typically land on a road that has like 2 lanes and maybe a median. We can land on if the road, if it doesn't have anything next to it. If it's a flat road through a flat field, we can land on whatever. Not a big deal. But in general, a 2-lane road with a center lane will fit us. We want to make sure that we're securing vehicle and pedestrian traffic. People like to walk up to the helicopter all the time, and we don't particularly want them to do that. So we want to make sure it's secure. And then the other thing about this is we are 15,000 pounds ish, and we land on these 4 little wheels. So if you would not drive your ambulance onto the field because it's too muddy or too wet or something like that, we don't want to land our helicopter there either. We have a lot of weight, and we have a tendency to get stuck. If we get stuck, it can cause some very serious issues up to and including a crash. So we don't really want to do that. So if it's been heavy raining or if it's been a lot of snow and that snow has been melting, that sort of situation, it's best to go ahead and pick us a landing zone that's hard packed. That'll be the easiest thing to do. That way we don't have to do anything. And it could be as simple as a driveway going through a field. The driveway is paved, the field is wet, but that allows us to actually come in and then slide over and sit on the driveway. That's fine too, right? So things like that, you can think outside the box. If we're landing on a major roadway, so if we're landing on 50 or something like that, we need to have traffic stopped in both ways because the oncoming traffic in the other lane, that their lane is not blocked, they'll all start watching the helicopter, and then we'll have another wreck. So if for the time that we're coming in and departing the scene, we need to close both directions. So this is that intersection that I gave you. This is in Baltimore County, but you can kind of see the point. So looking at this intersection, right, you've got power lines, you've got all sorts of overhead obstacles. So this is going to be a tough place to land us. So you see the picture on the bottom, that the double yellow going away from us. You've got trees that overhang that road. So we might not be able to get there because we'd have to thread between these wires and the trees and things like that. And then if you look up this Green Spring Road up here where this black pickup truck is in the upper picture, you know, you've got, it's a little bit wider, but you still got some overhanging trees. You still got a lot of wires. That might not necessarily work. So you might be thinking, man, I don't know that I can land an aircraft at this scene. But if we look at the overhead image, one of the things is you see this farm field right over here to the left. That's something that we're going to be able to see from the air. So when you request us, you don't necessarily have to have the landing zone set up perfect, done, coned off with a fire truck, all the things. You can request us early. We can help you, and we can be like, hey, there's a field over here that we can actually land on. And if you look at the picture of it, hey, look, we can actually land on it. If that's a little soft, we can maybe slide to this driveway, depending on how close this tree is. But this is a good landing zone, and it's walking distance for us over to this. So our aerial perspective can sometimes help you guys in picking a landing zone that's convenient to the scene. So I really just am trying to take off some of the pressure, right? If you early activate us, sometimes we're going to get to the scene before everything's set up and pretty and wrapped in a bow. But we're able to be self-sufficient. You don't have to worry about too much about that. Either as the medic crew or as the incident commander, we can figure out a way to set ourselves down safely. So if you approach the aircraft, generally you are going to be escorted by one of the flight crew. So always be escorted by the flight crew. You've got patient loading on the right-hand side of the aircraft. The lowest part of the rotor system is directly in front of the nose. So you want to be approaching from the right-hand side. If you're approaching for whatever reason without the flight crew, you're going to approach a degree diagonal to the nose, and you want to make sure you're making direct eye contact with the pilots and that they're waving you in. Our rotor disc is pretty high, so you don't have to do the whole mash, like crouch and walk. So I'd actually prefer you to stand up straight, walk, and look particular for hazards, obstacles, or things you might trip into. But you do want to secure any hats and loose clothing that might blow off, particularly if we're landing in a roadway. If we're landing in a roadway, a lot of times we won't take the engines all the way to idle. Leaving the engines at the flight setting as opposed to the idle setting, you'll hear it. It'll be a little bit louder, but it'll also cause significantly more wind in the general vicinity of the aircraft. So just always remove any hats or loose clothing. All right. Next little chunk is going to be mass casualty incidents. So this is good old USV. We've had multiple bone crushers there with multiple aircraft. And I think in this particular one, we had a third aircraft that came in after this. But the scene that I kind of pointed out, that intersection, we can get 4 helicopters to that scene in about 30 minutes. For Easton, things like that, we can bring in Delaware. We can bring in Trooper 1, Trooper 2, Trooper 6. We can, from Trooper 7, I've been over to Queen Anne's County quite a few times. One of the advantages that we have as a system is that we have a lot of aircraft that we can call and we can bring them in. So keep calling. If you have a MCI, call for what you need. We'll figure out how to get it to you. Your incident commander, your triage branch, or your transport branch can talk to Syscom. We can get you aircraft if you need aircraft. And to include, we can also call in private air if it's something that but we can spread patients out between numerous hospitals. So we might take, so from that scene, right, the closest pediatric center is going to be Sinai to that scene. For you guys, it'll be Hopkins, and you'll probably be using us anyways. But we can also take that patient down to Children's National, right? So if you have a bunch of kids, we have that ability to get down to Children's National. From the shore, it's probably going to be a 20-minute flight. But you think about a 20-minute flight versus a 20-minute drive, and now we're at a hospital, all the way down in DC. So we have a lot of options. We can take people up to Christiana. Christiana for you guys would be a significantly shorter flight than 24 minutes. But we have options that might not be in the normal Rolodex for you guys. So what we need and then what our typical procedure is for MCI operations is we'd like all the patients to come to one big landing zone. That smooths out the triage and the destination decisions. It really helps bring some order to the case. So I've had some really interesting ones where we've had to set up multiple landing zones, and those have gotten done and they've gotten done safely, but they haven't been as smooth as ones where we bring everybody to one spot. Our default for an MCI is we'll do first in, last out. So the first in aircraft will triage, leave one of the 2 crew members to start care, and they will coordinate with follow-on aircraft. So if Trooper 6 is the first one to you, they're going to be running the show for the aviation side and coordinating with Trooper 2, Trooper 1, Trooper 7 that are also coming in. And then the sickest patient will go to the next aircraft in. So the second aircraft that comes in right behind Trooper 6 is probably going to be Trooper 1, depending on where this is. Trooper 1 will arrive. They all get the call at the same time. Trooper 1 will arrive 3 or 4 minutes after Trooper 6. So the Trooper 6 guys will take a look, figure out who's the worst, and be like, 1, take that guy and go. Then 1 takes that guy and leaves. And that leaves Trooper 6 able to manage the whole scene and make sure that there's continuity. This is also situation dependent, though, because sometimes we don't have that many aircraft available, right? If it's a busy summer day and we have a lot of missions going on, we may only have 2 aircraft to send, in which case the first aircraft might do something different, or they might take 2 patients, go drop them off at shock trauma, and come back to your scene, which is another option that we can do. If there's not a landing zone big enough to put the aircraft, then we might just have to take 1 and leave, and then have the next aircraft come in and repeat the process. So it just kind of depends. We do some internal training with this pretty regularly. But you can expect us to kind of come into the landing zone and at least take a look at everybody. All right, so that being said, let's talk a little bit about our new weather capabilities. So we've expanded our ability to fly in instrument flight rules. Instrument flight rules basically is where we can't see in front of us and we're flying based on our gauges. It would be kind of like driving a car based on looking at the speedometer and your tachometer, right? We have a lot more gauges than that, but that little short clip, and I'll play it again real quick, but that little short clip shows you kind of what it looks like when we're flying IFR conditions. Our pilot's inside looking at all his gauges, and outside the window, it's just pure clouds. So it's a useful tool for us to get patients to shock other specialty centers, adverse weather blanket state. But one of the things I want to point out is that IFR flight is very safe and very controlled. So when we fly, we pick up and we fly the direct route and we go traffic control, they don't actually follow us. We just let them know, hey, we're here, we're staying out of your way. And they're like, cool, no big deal. They'll let us know if other aircraft are around, but they're not actually controlling where we go. If we're on IFR, we are always under the direction and constant supervision of air traffic control, which makes it significantly safer. So talking about the differences, so if we have 3 miles of horizontal visibility and 1,000-foot ceiling from the bottom of from the land to the top of clouds, then we are in visual flight rules. The rules for that is we can see where we're going and we can just go to wherever. So we can land on an intersection, we can land on a farmer's field. It doesn't matter because we can see where we're going. If we are instrument flight rules, we have to follow prescribed paths in the sky. They're like GPS breadcrumbs, and we have to follow them. We don't have any option to deviate. We must follow that path. So we don't always get to take the most direct route to the scene or to the hospital. We can also do hybrid flights. So we can fly to the scene under visual flight rules, leave the scene, pick up into instrument flight rules, and then kind of fly to the hospital in instrument flight rules. So that can be useful if the shore looks clear, but the other side of the bay is foggy or rainy. We can do that as well. For instrument flight rules, we have some mission planning minimums that are more stringent than what the FAA requires. This isn't for safety, it's for patient care. So the FAA determines what is safe to function and what is safe to operate in instrument flight rules. But we decide as MSP, we decide that before we lift off and accept a mission, before we tell you, yes, we're going to take that patient, we need 200 feet of a buffer above whatever the published approach minimum is, and 1 mile of visibility as a buffer above that. And I'm going to show you a demonstration of that here in a second. So this is the approach into shock trauma, and some of what I talked to you about, right? This is what our pilots look at, and all sorts of things like that. But so it's like this series of GPS breadcrumbs. So that we're gonna hit this point in space called Okud, right? These are just they're assigned at random. So we'll hit Okud at 2,400 feet, and then we'll drop down slowly to Thol at 1,600 feet, and then we'll come down to Wupta. So we have all these different points, but basically we're just going to be following these breadcrumbs down in the sky. And in this case, it is a straight in approach. This visibility here that I have down circled is what we're actually gonna use. So that visibility, that 344 feet, right? So we need 344 feet above ground level in order to shoot this approach when we're flying. So prior to launch, we add 200 to that. So you round up to 400 and then you add 200. So prior to accepting a mission, we need 602 at shock trauma. But once we're flying, we can take it all the way down to 344 feet and 3/4 mile visibility. So we have a significant ability to get into shock trauma even when the weather's bad. And other hospitals, I'm using shock trauma as an example, but other hospitals also have these approaches. So that's one of the things that we can use is we can use like another hospital to come in, shoot this approach, and you guys meet us there. This is going to take a second to load, I think. There we go. This is the bottom of that approach in bad weather. So sorry, it's going to take a second. I guess it's my internet connection, but it's a worthwhile vote. So this is our pilot's view coming into that approach at shock trauma. So this is just before you get to that what's called decision point, and this is kind of what we're able to see. So I really hope this video puts to rest all the rumors of if there's cloud in the sky, MSP won't fly, because here they are actually flying in the clouds. But we do have a really significant ability now to get into shock trauma when the weather's poorly. I do want to point out though that doesn't extend to the winter time. Our aircraft is not equipped for icing conditions, so we don't have anything that will like melt ice off of the aircraft. So if we can't fly in a cloud when it's below freezing, because we'll accumulate ice. Ice is heavy. Ice disrupts our ability for our wings to make lift, and will sooner or later fall to the sky. So no icing. But other than that, timepiece, we're good. Some of the other questions I've gotten about thunderstorms, and no, lightning is still a no-go for us. But if there's just kind of like clouds, those kind of foggy days, we might have the ability to get to it. Key takeaways for this is that they're going to require more planning, right? We can't just pick up and go where we want to go. So we have to plan. We have to check the weather. We have to do all these things. And we have to make sure that we fit into the air traffic control sequence. Because while we're trying to fly on our little GPS breadcrumbs, there's also a Southwest flight that's trying to land at BWI and his GPS breadcrumbs. And we have to fit into a sequence because we can't see each other. So the air traffic controller has to move us around and make sure that we won't go bump in the clouds. So sometimes we're going to delay a little bit to launch. We may not be able to get off the ground as fast. The en route times might be longer because we're not able to fly direct from point A to point B. And our destinations will be limited. We may not be able to land at your scene. So this is one of those things. If you make that request early, what we'll do is we'll get that request and we'll do our mission planning. And Syscom will come back and tell you, hey, Trooper 6 can take that patient, but you have to bring it to the airport, or you have to come meet them at this hospital. I'm trying to remember off the top of my head how many or what places have the instrument approaches on the shore, but the pilots are really good at that and doing that mission planning. So make the call and we'll give you that option. We'll say, hey, if you bring the patient here, we can take them. And then it's going to be up to you to figure out whether or not that makes sense for your patient care. If it doesn't, one of the things that we are also starting to do more regularly is come out with the blood or with our particular supplies from the helicopter, put that stuff in our police cars, and come meet you. So that's another option that we can do if that doesn't make any sense. So some future expansions, basically, we can build these GPS breadcrumb approaches to any location that is clear of overhead obstacles. We typically need a lighted helipad. Now, it doesn't have to be like a lighted paved whole thing. We have a couple fire departments around the state that have a lighted helipad in their backyard, basically next to the fire station. If that exists, we can build a point in space approach to it, which means we drop those GPS breadcrumbs down to that spot. That whole process is about $25,000. So it is expensive, but it's something that, we've had some interest from other fire departments putting like 1 or 2 in their county. So Garrett County right now is working on, we're working on one with them, and then Ocean City Fire Department is also working on one, or the city of Ocean City is working on one. That one's going to go to a park in North Ocean City, and so that'll be the designated landing zone. If the weather's bad, they'll just go there. So this is something that, if you know people at your firehouse that are doing grants and are doing these sort of early projects, if it makes sense in terms of the location, then we'll do it. And there's some places where it's not going to make sense because of the location. There's some places where, well, we could use the hospital a half mile down the road, or we could use whatever. There are going to be some limits, but it is something that we can build out, and you will probably see this program expand over the next couple of years. So now we're going to get into some of our non-traditional missions. And the only reason I phrase it this way, they're very traditional to us, but they're not as often done for kind of routine EMS providers. This is an example of one of our aircraft. I believe this was Trooper 7. Trying to remember. It might have been Trooper. No, this was Trooper 6, I think. But Trooper 6 doing a hoist off the back of a Carnival cruise ship. So somebody in this case was on a cruise outbound to Baltimore, had a medical emergency, needed to be removed. This is something that we do once every couple of years. And this is just one of our hoist missions. So we do a lot of hoist missions in general. We train pretty extensively across the state. So, and I think some of you guys have come to join us in some of our hoist training, and I'm going to send Lindsay some additional dates so you guys can come join us in the fall as well. But so we have a lot of different things that we can do. So we can provide some of that search and command assistance. We have a camera. We're looking to significantly improve our capabilities to do that in the next year or two. But we can search and help you locate patients. So if you've got a patient, one of the ones I heard on the radio someplace was a guy having a heart attack, a guy having a seizure on a boat. Okay, if that call's coming into your 911 center, one of the things that you can do is we can help you locate that boat. We can help you direct it in. We might be able to hoist somebody down depending on the size of the boat and where it is. We might be able to hoist somebody down and start patient care. But we're able to do those sort of things. Same with like hiker or hunter injured in a remote area, right? You have a hunter that has an accidental gunshot wound in a duck blind. He might not have his exact location. He might not be able to pinpoint exactly where he is. And so if you're having trouble locating or accessing a patient, that's one of the things that you can call for. That is not at all covered by the Maryland medical protocols. So it's good to go, right? You're just calling us for operational support. If you have a large incident that you're working with the fire department, right? You've got like a brush fire, things like that. We can take people of your command team up and show them the perimeter of the fire. We can do sorts of things like that. Like we have those seats that we can use. So we can we can place one of our flight paramedics on the ground via hoist. They can do all their packaging and extraction of the patient. We can do this if we're forced to. We can do this entirely solo, right? It's kind of hard to put somebody on a long backboard solo, but we can do it. If there's no way for other responders to access the patient, we can do that. One of the things that gives us a distinct advantage in these circumstances is that we're able to transition to a medevac immediately upon departing the scene. So as soon as so you see this trail line that's attached to the litter here, as soon as that trail line is away, our medic is back in the aircraft and the ducts, we are now en route to the hospital. So that is one of the things that makes us a unique program, that most programs that are out there can either hoist or medevac, but not both. We can do both, and we can do both to a very high level of safety. So it's one of those things that if this is something that benefits your patient, we can do that. We have hoisted patients that have like isolated ankle fractures, things like that. If you need us to extricate your patient, to remove them from wherever they are, that is not covered by Maryland protocol. So that is a operational decision. So we can have people that are walking or they're stuck in mud, they're not injured at all, and we can still hoist them. Just kind of depends on what the situation is and how far or how difficult it is to access them by ground. But we're the by far one of the safest hoist platforms in the area because of the way that our system is set up. We have 2 pilots that are hoist trained. We have 2 crew members in the back. We have twin engines. We have a lot of redundancy and reliability. But we do also take a little more time to mission plan these things. So I hope you guys are hearing this. When I say is we're very adaptable to circumstances, and we can do a lot of things, kind of on the fly. But we brief, and we are very methodical in our planning for these missions, like IFRs, like aerial rescues. If the hazards increase, so does our level of briefing and our level of preparedness, and we slow things down a little bit. So it is important to give us that call early and give us a little bit more time to do the planning. If you're at the hoist site, this is kind of the minimum personal protection equipment. So you want to have helmet, eye protection, and gloves. Helmet's really important. We've knocked tree branches, things like that down on rescue personnel on the ground before because of our rotor wash. We put out hurricane force winds out underneath the aircraft. So you need those helmets. You need eye protection because of the aforementioned hurricane force winds. And you need gloves, right? We might have you hold a rope for us or do something like that. So gloves is useful. And then those little foam earplugs are fantastic. Ear protection, highly recommended. But the reality is we'll be in and out, so it shouldn't be that bad. Some of the devices that we'll use. So we use this aerial rescue vest. So I'll list the aardvark because it's, if you really slur ARVQC, maybe that's what it sounds like. But we can use this on an ambulatory patient. So if they're completely fine, they're just heat exhausted, and there's not a good way to get them out, we can lower them down, put them in this, and take them back to the aircraft. We do carry it with a helmet for the patient just for safety purposes, but it folds up into this nice little bag, so it's a really easy thing to hook up and get out. The patient doesn't have to be standing, so like if they are just like sitting with an isolated ankle fracture, we can put them in this and still take them out. Our PEP bag. So this is kind of what we're going to use for our supine patients. Key thing with this is that we are packaging them to a standard backboard. If they're starting to pull out the Stokes basket, that big metal thing, we will not put their Stokes basket in this bag. It has to be a standard backboard. And we're not hoisting their Stokes or like anybody else's equipment. There's some lessons learned in Blood, luckily not with us, but with the Coast Guard in terms of like hoisting another agency's equipment. For liability, for all the other things, unless it's our stuff, we're not hoisting it. So, use that standard backboard. It will connect into there, and we can secure it inside of that board. So secure the patient on a backboard. We'll secure the board inside the PEP bag, and then we hoist the PEP bag. So trail lines, you guys will see, used to prevent us from spinning. So spinning is one of the things that is really common with hoist operations. I think a lot of us have seen that video, the people in Arizona, where they had that poor little lady like spinning on the freaking top. I think somebody clocked her at like 100 and something rotations per minute. So one of the ways that we mitigate that is trail lines. So trail lines are a rope from the end of the device to the ground. Basically, you're just going to kind of gently hold on it to make sure that we don't spin. But you're definitely going to want gloves because that rope is going to feed through your hand and it's going to get hot. If the trail line snaps or breaks away or anything like that, it's not a huge deal. We have other ways to mitigate the mitigate the spin, but that's the primary. So ideally, in a perfect world, we'd use 2, 1 on each side. 1 will work. So we see this in the middle. But the biggest thing is we want to make sure that we have that angle. If we are straight up and down with that and you pull on it and pull it taut, it will make an axle from the aircraft through the patient to the air to the ground and cause that spin. So it's important to keep that 45-degree angle if you are stuck with a trail line. Give me 1 second to let the video load here. Should be another video. So the other thing that we do to mitigate our rotor wash is we do this dynamic hoisting. So you're going to see the aircraft come in and they'll lower the victim down, and then as we leave, we'll be lifting the victim in the rescue. One of the things that does is that keeps our rotor wash down and hopefully victim and the rescuer in clean air as we approach the scene. So protocol updates. So a little bit of a jarring transition, but one of the things that this is a new slide that I had to throw in there. So we've had some changes to protocol updates and specifically to the trauma decision tree. Looking at for category alpha, we're now looking at a motor GCS less than 6. So not necessarily GCS less than 14, GCS less than 13, and that stuff like that. Motor GCS less than 6. So they can't follow commands and they can't make any purposeful movement. If you're looking at a patient that is semi-conscious like that, like, hey, squeeze my hand, and they do it, then we're good, right? They have that motor GCS of 6 because they have that voluntary purposeful movement. Systolic blood pressure, that hasn't particularly changed, but the one that's changed is heart rate greater than systolic blood pressure. So I talked about that a little bit in the scenario. That's that shock index. If your patient is older than 10 and your heart rate's greater than 10, than your systolic blood pressure, that counts as alpha. And pulse ox less than 90. For Bravo, some of the new ones. The new ones for Bravo is going to be active bleeding requiring a tourniquet or wound, right? So if we are packing a wound, doing a tourniquet, something like that, that now counts as a Bravo. Oh, I went all this time and put... I forgot to put arrows. So some other things. So for fall from height, high-risk auto crash, right, they're going to be that 30-minute drive time. I don't think any of you guys are within 30-minute drive time to a trauma center, so you don't worry about it. You can still call us. No big deal. Just the key thing is they have to be consult approved. If we're already en route, the receiving facility just has to approve that, yes, they can come by air. So if they're already en route, one of the things that you can tell them when you make that consult is like, hey, I've got this, this, and this. Aviation has already been requested. They're 5 minutes out, or aviation's on scene, or whatever. Final thing I'll throw in there is that we're always looking for paramedics. So if you're interested, if this sounds like something you want to do, we want you. We always like paramedics, and we like the people that are that know their own local jurisdiction and know the people that they work with. So we try to, if you want to, we try to take people that are from a certain geographic area and like eventually work them back to that area. Can't always promise that'll happen quickly because you sign the box where you'll work anywhere in the state, but that's one of the things that we try to do. So it is always kind of helpful for us. This is kind of generally what we're looking for, but we're always hiring. That's about it. Does anybody have any questions? I've covered a lot of stuff.
Yeah, Adam, thank you so much for taking the time to speak to us. I really appreciate, you going over all of this new stuff and kind of what the expectations are of MSP and how to make it safe for everybody. Like Adam just said, let's turn it over to questions. You can either ask your question outright, or if you'd like to type it into the chat, you can, and I'll ask it for you. Thank you, Amanda, for the hand clap. Anybody questions, comments, concerns? Okay, so if there are no questions, that's totally fine. If you have questions later on and you decide that you would like to ask them, please feel free to email them to me. I'm happy to ask them for you. I want to make sure that we are as knowledgeable as possible when it comes to advocating for our patients and working with other agencies. Again, Adam, thank you so much for taking the time to talk to us. I really appreciate it.
Yeah, no problem. And I know the Trooper Six guys would be happy to answer anything. So if there's a question, you see them on a call. If you've got time, ask them questions. We're all pretty friendly, I think. So at least I hope we are.
Yeah,
um,
I would say so.
so
Okay, great.
okay.
Scotty has a question. Is Syscom changing their rules with IFR? Do you know that?
So Syscom isn't. So we changed our rules, and so Syscom kind of works for us. So Syscom will advise. Basically, the way it works, we all share like a CAD dispatch program, and our aircraft will let the Syscom operators know whether we are hard down, whether we're available for IFR, available, or just straight up available. So based on that, Syscom, when you make the phone call, they should be telling you guys, um, hey, they're only available for IFR. They need to get some planning done. We'll call you back, or we'll get you an updated ETA or something like that. They should be kind of working with you. I mean, I will say, the throughout the aviation command's history, and we've got some people in Syscom that were around in 2008 when one of our helicopters crashed in bad weather. So this has been a long time convincing people that this is safe and effective, and it really is. I have no problems putting my butt on an aircraft that is going to go into the clouds because there have been a lot of medevac helicopters that have encountered bad weather when it was unplanned, and when it's unplanned, it is an absolute emergency. So if you're not planning and not prepared to go into the clouds, or if your aircraft is not set up to go to the clouds, it does not have the right equipment, then it's an emergency. But our aircraft is set up and prepared, and we tell our guys basically just to plan for it, and right, and we plan for it and train for it, and that mitigates those risks. So I think the point that I'm getting at here is we have some people that this is going to require a culture shift because they've been used to for years hearing that flying in the clouds is dangerous. And now we're telling them, no, it's not. And so, unfortunately, Syscom to us, they're our window to the rest of the world, but it's kind of like you guys in dispatch center. How often do you get a chance to sit down and actually talk to your dispatchers and explain to them like, oh, hey, no, like this is what we're doing for this patient, right? We're a little bit of a separate world. So we're working on that stuff, but our rules are Syscom's rules. So if we can take the flight, then we're good to go. Syscom should not be rejecting missions if we are available to take the mission. If you're having issues with that, or if you have something that in particular that you want me to track down, what I would say is, have Lindsay email me and I can track down. A lot of times with these things, the game of telephone is usually where it gets lost. So if you have like a specific thought or a call that you're thinking of, let me know and we can try and figure out what the actual root cause was or what happened then.
Very good. Any other questions? Okay, so if there are no other questions before we go, whoever is Alex's iPhone, I need your provider number for CE credit. Other than that, everyone is free to go if there are no more questions. All right, everybody, thank you.